welcome back to another ID bite-sized video. My name is Nick Stornelli. I am an infectious diseases clinical pharmacy specialist here at Curling Clinic. Today we'll be talking about a really exciting topic in antimicrobial resistance in urinary tract infection. And I hope you leave today's talk with a few additional pearls in your back pocket. So what are we talking about when we're thinking about antimicrobial resistance in urinary tract infections? The three big buckets for gram-negatives are ESBL producing Enterobacterales, or AMP-C beta-lactamase producing Enterobacterales, carbapenem-resistant organisms, as well as Pseudomonas, which you may also encounter in the inpatient and outpatient practice settings. Then also from the gram-positive side are vancomycin-resistant Enterococcus faecium, or VRE. And for today's talk, we'll focus in really on our gram-negatives. One thing to really point out before we get into talking about some of the treatment pearls are setting the record straight for gram-negative resistance in UTIs and in growth in the urine. Urinary isolation alone of a resistant organism or of any pathogen is not necessarily an indicator of treatment all the time. Treatment principles of urinary tract infection still very much apply, even when you are having a patient that has a urine culture that's positive for a pan-resistant isolate. Really only treating in the population that are symptomatic, and then applying the principles of appropriate ASB treatment in those where the guideline recommendations are really based. It's really important to distinguish if symptoms are present, as well as the adequacy of the sample. Getting a good patient history to just really describe what symptoms they're having, dysuria, suprapubic tenderness, frequency and urgency paired with those kind of painful urination symptoms are probably the key indicators of cystitis. And then pairing that with if the patient has pertinent positive signs of constitutional signs of infection, systemic signs that might be present that may indicate more of an ascending infection, or the kind of typical flank pain that you may see with someone with pyelonephritis. And also thinking about how well the sample was collected, or the adequacy of the collection method, is very important for assessing urine growth of organisms, particularly gram-negatives with significant resistance. So was that sample collected from an indwelling catheter? Could the catheter be removed or exchanged with a fresh sample completed upon removal? If it's possible to get a straight catheter sample in someone who's had a fully removed, that would be the most ideal. So we talk a lot about appropriate treatment and not over-treating ASB or patients that are without urinary tract symptoms a lot. And so it's really important to kind of understand the why. We talk a lot about the consequences of antimicrobial exposure, resistance development over time, as well as the impact to patients on C. difficile risk, which is a big buzz on the inpatient and outpatient side, and something we really want to avoid for our patients. But what we don't really always focus on is what are the kind of efficacy impacts of overtreating. And we just want to highlight a study from 2012, which is a really important piece of literature in this space. That was a randomized placebo-controlled trial looking at women aged 18 to 40 that were asymptomatic at enrollment, but did have bacteriuria. And what they looked at was the endpoint of symptomatic UTI development at the 6-month and 12-month time frame. And they found a clinically and statistically significant increase or difference with a lot more patients in both the 6-month and 12-month window that received antimicrobials that were asymptomatic, developing symptomatic UTI within the time frame. So just want to point out the number needed to harm, that within 12 months, the number needed to harm was 2 in terms of developing symptomatic UTI when patients who are asymptomatic are exposed to antimicrobials. So a really great takeaway from the study is to not treat when the patients are not having symptoms, and try to preserve as best as possible our antimicrobials for when there are actually true symptoms of urinary tract infection. I want to start out with a case, talking about our extended spectrum beta-lactamase. What does this look like in clinical practice? I'm sure you're very familiar with our susceptibility reporting and how these show up and how you're identified to them. This is a 50-year-old female that has a urine culture obtained at your primary care office after coming in for dysuria evaluation, prescribed empirically cephalexin kind of after the visit, and you note that the results have come up after And the patient does have significant allergies listed to levofloxacin, noted as tendon rupture, as well as trimethoprim sulfamethoxazole as anaphylaxis. So you're really looking for an option that's going to provide adequate therapy without the antimicrobial toxicity risk or allergic potential as some of the to elicit a good outcome for your patient. Pretty typical for ESBL E. coli. We see that our beta-lactam backbone therapies for most gram-negatives are resistant, cefazolin, cefepime. We have ertapenem available, or carbapenems are generally our drugs of choice for ESBL, but they are available as IV most commonly. We do have some other options listed as susceptible, our levofloxacin, as well as our trimethoprim sulfamethoxazole, but probably not great options given the prior history of tendon rupture and anaphylaxis. And then you also note on here we have nitrofurantoin as resistant, which is a potentially great option for ESBL when susceptible, but is not something we'd be able to use. So you may think, what do I do next when I get this culture report? And there's really no oral option on the initial culture report. So as I mentioned, ESBLs, they're a pretty pesky resistance for that are acquired resistance for our Enterobacterialis group most commonly, confer resistance to our first through third generation cephalosporin, so not atypical for that susceptibility profile that what we saw on the last slide. We generally have some really great oral options, but a lot of the options are precluded by potentially adverse effects, potentially they may not have a high degree of empiric susceptibility. There may be some variability with their susceptibility, as we saw with nitrofurantoin. And then one thing I want to leave for you all today, as far as the antimicrobial pearl here, is don't forget about fosfomycin. As you probably saw in that initial susceptibility report, it was not there. But our lab actually runs fosfomycin automatically on urine cultures for E. coli in the outpatient setting that are positive for ESBL production. And so this drug has really great activity as a quinolone sparing option for E. coli, ESBL E. coli, and it does also have activity against Enterococcus faecalis. Really, the niche of this drug is going to be for your ESBL positive E. coli urinary isolates. It is, again, automatically tested for fosfomycin, but the thing to really note here is that it may take 1 to 2 days after the initial susceptibility report comes back to see the test result for fosfomycin. So once you get that initial flag on the susceptibility report, it may not be the end all be all susceptibilities. Come back to that report 1 to 2 days after, and you may be able to see that fosfomycin is a treatment option for your patient. One thing to note is it's not a solid oral formulation that's available in a powder packet that gets mixed in with about 3 to 4 ounces of water, has about an orange tangerine flavor, just to give your patient some expectations on what they're going to be giving themselves once you prescribe this, because the packet formulation is a little bit interesting. Can be used for both uncomplicated and complicated cystitis. But one thing to note is the single dose is for uncomplicated cystitis alone. And then the repeated dose every 48 hours for 3 doses would be what we would utilize for complicated cystitis. And given it has such great urinary penetration, it actually lacks a lot of the renal tissue penetration that we would rely on for antimicrobials in the setting of pyelonephritis. So revisited here, we got our susceptibility result back for fosfomycin, and it was susceptible, and the patient had their prescription changed to fosfomycin and was hopefully symptom-free and sent about on their way. Case 2, Pseudomonas. So this is LB, a 50-year-old female. Once again, dysuria coming into the primary care office, prescribed empirically nitrofurantoin, but you know that the susceptibilities came back with Pseudomonas. Nitrofurantoin does not have any acknowledgeable activity for Pseudomonas, so you're looking to change your options up, and you see the following susceptibility report. Our beta-lactams, cefepime notably, which is our institutional preferred empiric anti-pseudomonal option, is susceptible in this case. Our fluoroquinolones, which are really the only oral mainstays of pseudomonal treatment, are resistant. And then you note that the tobramycin looks to be a potential susceptible option, and you have further questions about what treatment to provide your patient. And so I want to talk a little bit about an option that I think is really slept on and not often asked about that could be an offering for your patient in these types of scenarios where, for Pseudomonas particularly, there's really no option orally that we would really trust for either systemic treatment or even just UTI treatment outside of the fluoroquinolones. And so, as a means to potentially divert inpatient admission or to give something as an intramuscular route, thinking kind of outside of the box, we do have our single dose aminoglycosides that can be utilized in the situation of uncomplicated cystitis. You may be thinking aminoglycosides. I haven't used those since inpatient wards. It is something that is like probably not very familiar, but I hope that this gives you a little bit of sense of an option that could potentially mitigate the need for coming into the ED in the primary care setting or even coming into the hospital for admission. These drugs, tobramycin, gentamicin, are primarily excreted in the urine with therapeutic levels that persist for days. They have really high rates of urinary excretion. There's the post-antimicrobial effect. So even after the dose, the drug is given and kind of subsides below MICs of the organism, they're still exerting an antibacterial effect. And they do have low C. diff risk, which is great. And when used in a single dose, as an intramuscular or even an IV as a single dose, across the spectrum of renal function and age, they do have a very minimal toxicity risk. The toxicity risk for both ototoxicity and nephrotoxicity does increase the more frequent that you administer these, but the novelty of cystitis treatment being a single dose does mitigate that risk basically altogether. So you are probably asking, show me the data. This sounds great, but where is the data? We do have really awesome data. We do have a systematic review from 2018 that looked at 13 studies and over 13,000 patients receiving single dose aminoglycosides for urinary tract infection. They had reported on microbiologic cure rates, which is generally sterilization of the urine, which is probably not the most important clinical endpoint, but just to note, strong clinical cure rate noted, microbiologic cure rate noted for single dose aminoglycosides. And then a clinical cure, which is probably the more important endpoint, was overall very great, 82% and 94% in the two studies that did report, with very low adverse event rate reported here compared to either oral or IV alternatives. So 0.5% amongst all of the patients included in that systematic review. So a potentially really great option for a fluoroquinolone sparing drug for resistant urinary tract infections. You may be asking, how do we make this work? I have never had tobramycin in my clinic. I would generally encourage you to discuss with your either clinic manager or whoever is in charge of ordering medications to your primary care site to evaluate if getting an aminoglycoside is an option and what time frame it would take for you to get that. Tobramycin is generally our preferred aminoglycoside just because of the fact that it does have better coverage of Pseudomonas. The institution that makes breakpoints for susceptible, resistant, intermediate actually removed gentamicin for Pseudomonas breakpoints. And so tobramycin is really the option of our choice from the stewardship team for use to be deployed in these scenarios for resistant urinary tract infections. Okay, so we have our patient. We're going to give tobramycin in our clinic. We're generally going to use a 5 milligram per kilogram dosing. The dosing is something that can be a little bit flexible, and we generally want to think about how we're going to administer. So as an intramuscular injection, when we come up with our dosing here, we want to make sure that we are using our total body weight, and then we're going to use adjusted body weight if their total body weight exceeds 20% over their ideal body weight. So you need to think about your patient's weight first, and then you also want to think about rounding to the nearest easily administered intramuscular volume. And so that's another thing to think about. We do have a soft max of about 4 milliliters per syringe. So you're going to want to instruct nursing staff in the patient who is getting a dose of 320 milligrams, where you would be splitting 8 milliliters total into 4 mLs each. Instruct them to get a 5 ml syringe to drop 4 ml in each. And then for our patients with lower muscle mass, you want to lower that max volume to about 2 to 3 milliliters per dose. Um, the tobramycin concentrations for the vials in this example here is a 40 milligram per 1 ml. So it's kind of gives you an idea of how to assess the total volume that's going to be administered in a dose for a milligram basis. So our example here for our patient is they're 76 kilograms, 65 inches, 57 kilogram ideal body weight. And so their adjusted body weight, because their actual weight is exceeding 20% over their ideal body weight, we would use 64.6 kilograms to dose them. We would multiply that by 5, which gives us 323 milligrams. And then we're going to round that down to 320 milligrams, and that's an 8 milliliter total dose. And then because our concentration is 80 milligrams per 2 ml, 40 milligrams per 1 ml, we're going to split that dose into two 4 milliliter intramuscular syringes that are going to be given in large skeletal muscle. So the glute or the delt, prefer for the two injections to be given opposite of each other in the opposing muscle rather than just the same muscle, just for the patient satisfaction. You may be thinking, wow, that might be painful for the patient. And yes, certainly something you want to inform them before administering, but also kind of frame it in the context that you are potentially diverting their need to go to the ED or the hospital when there's really no other oral option available, and IV options are generally the only thing that you think are going to be able to treat your patient. And so I hope with that you take away a few pearls thinking about our intramuscular aminoglycosides for multi-drug resistant organisms and urinary tract infection, cystitis particularly. And then also don't forget about the fosfomycin susceptibilities. They may take 1 to 2 days after that initial ESBL positive result comes back. Check back in the chart. If you don't see anything, reach out to the microbiology lab, reach out to antimicrobial stewardship if you have a question. And then again, for the intramuscular tobramycin, our antimicrobial stewardship team is always available to discuss if this is a potential option and talk through the dosing to help you navigate some of these really difficult resistant cases. And with that, I thank you for your time and joining us for another ID bite-sized video. Again, my name is Nick Stornelli, one of the infectious diseases pharmacists. Our team is reachable via Perfect Serve as well as via email. And I do want to just give a plug for our new resource, our mobile app that's provided through Elois Medical. There's a QR code that's provided here that'll link you to where to download the app. And you can check out our Carillion Clinic antimicrobial stewardship resources through this app, including a MDRO or multi-drug resistant organism treatment guideline that features some of these options discussed today. You'll want to create an account with your Carillion email, search in the all spaces function on the app for Carillion, and then once you see our resource pool, you can just hit join and you'll have access to a lot of great antimicrobial stewardship resources. And with that, we will see you on the next episode.